Welcome to this ASCO University Weekly Podcast. My name is Carolyn Hendricks. I'm a breast-dedicated medical oncologist in Bethesda, Maryland. Today I'm going to be talking about a series of medical errors which occurred with use of an electronic health record system and some steps that were undertaken to prevent these errors from occurring in the future. The patient is a 60-year-old woman who presented with a mass in her right breast. Her evaluation showed clinical stage 2B infiltrating ductal carcinoma, which was hormone receptor negative and HER2 overexpressed. During her initial consultation, the combination of neoadjuvant docetaxel, carboplatin, trastuzumab, and pertuzumab was recommended. However, with the use of an extensive drop-down menu in the EMR, the incorrect combination was selected, incorporating paclitaxel in place of docetaxel. This initial error was detected and corrected during a chemotherapy education session with one of the nurse practitioners in the practice. During that nurse practitioner visit, an electronic order for an incorrect dose and schedule of oral dexamethasone as a supportive medication was generated. Although our chemotherapy order templates are standardized, regimen-specific pre-medications are not, and this resulted in a prescription error. This second error was detected on the day of the patient's first chemotherapy infusion by one of the infusion nurses. For her second cycle, the patient's carboplatin dose was missing from the computerized order because the serum creatinine was not available in the EMR within 7 days for recalculation of her creatinine clearance. This hard stop was overridden, and a verbal order was given to the infusion nurse to use a prior creatinine to estimate her clearance for this cycle. The next day, her pre-treatment creatinine was found to be elevated, resulting in the third error, an incorrect dose of carboplatin administered. The patient was given additional IV fluid, and fortunately her creatinine normalized. On the day of her third cycle, her electronically generated chemotherapy treatment calendar included an evaluation by an infusion nurse only. During that visit, the patient reported significant treatment-related diarrhea, which was documented in the EMR by the infusion nurse under the chemotherapy administration section, but no specific intervention was undertaken, and that note was not reviewed by either a nurse practitioner or a physician. The patient had a follow-up electronically scheduled provider visit the following week. However, in the interim, she became severely dehydrated, requiring hospitalization, and that eventually resulted in a 1-month delay in her neoadjuvant chemotherapy regimen. During her hospitalization, the oncologist rounding in the hospital recommended modification of her regimen with omission of pertuzumab for subsequent cycles. Because the hospital utilizes a different EMR, and because the hospital records are not automatically incorporated into the practice EMR, when the patient presented in the office after her discharge to resume her chemotherapy, she was nearly administered full-dose pertuzumab. This final error was only detected when the infusion nurse was preparing to hang the medication, and the patient mentioned to the nurse that she had been told in the hospital that she should not receive it again. This case illustrates 5 EMR-related chemotherapy errors, including the use of the wrong electronic chemotherapy template, the impact of the lack of standardized electronic prescriptions for supportive medications, a verbal order override for an electronic order for carboplatin dosing, the lack of review of a chemotherapy RN administration note because it was housed in a separate section of the EMR, and the use of 2 non-integrated EMRs in the office and hospital settings. These errors resulted in a near-miss administration of pertuzumab. The following steps were undertaken to help reduce these types of errors in the future. The electronic chemotherapy templates were reorganized and streamlined. Standardized prescriptions were created for supportive medications. A new policy was developed regarding verbal order overrides of computerized chemotherapy orders, and same-day serum creatinine testing was implemented. Modifications were made to the infusion RN documentation notes to make them more easily accessible to the physicians and the nurse practitioners. And attempts are being made to integrate the hospital and practice EMRs. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more podcast episodes, visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.